Hi, I'm Sophie from In the Mess, and today we're going to talk about hyponatremia. Low sodium levels are a common clinical finding, and it can be confusing to try and work out a cause and what to do about it. This reflects the fact that sodium is involved in so many biological processes and is usually tightly regulated, so when it goes wrong, it can be tricky to fix. Because sodium is intrinsically linked to water, you need to remember that imbalances in your water level will cause abnormal sodium levels. So the first thing to remember when you find that your patient has a low sodium level is to check their fluid status. With low sodium, patients can be drowsy, confused, or even have seizures. In patients who are hypovolemic, here are some things you need to remember. If water leaves, it can drag sodium with it, particularly if the fluid being lost is an electrolyte-rich mix like vomit, diarrhea, or sweat.
Ew, gross!
A really important cause of hypovolemic hyponatremia is the use of certain medications like diuretics, which can cause large amounts of sodium and water loss. Finding out that your patient has been recently started on bendraflumethiazide can give you a relatively easy fix. Other things to consider is whether your patient has signs of adrenal insufficiency like Addison's disease. This may even present as an Addisonian crisis. The symptoms of Addison's disease are vague, things like fatigue, weight loss, GI upset and dizziness. But an Addisonian crisis involves hypotension, collapse, vomiting, and may include abdominal pain. It can be autoimmune, or it may be secondary to withdrawal of steroid medications. These patients require urgent resuscitation with oxygen, IV fluids, and steroid replacement. They may carry 100 milligrams of IM hydrocortisone to give themselves as an auto-injector, but 100 milligrams IV hydrocortisone is a useful treatment to give in an acute setting. If you suspect your patient has adrenal insufficiency, escalate this urgently to your seniors, as this patient may need admission to a specialist endocrine ward or to critical care. If you suspect your patient has adrenal insufficiency,
your patient has adrenal insufficiency.
All right.
Caption that.
Let's say you say that. Hypervolemia. For hypervolemia, think failures leading to fluid overload: heart failure, renal failure, liver failure. These patients may also present with signs of fluid overload such as peripheral edema or pulmonary edema. These patients probably require a fluid restriction and may need diuretics to restore a normal fluid status. In refractory cases, dialysis may be required to restore fluid status, but you would not be expected to start dialysis in any of these patients without speaking to a senior first. In euvolemic hyponatremia, patients with a normal fluid balance and hyponatremia can be tricky to diagnose. Work systematically to identify a cause. Look for diuretics such as thiazides, which may be the precipitating factor. Ask the patient how much they drink, and get the nurses to record input and output to examine for primary polydipsia. Sodium homeostasis is under the control of antidiuretic hormone, ADH, and abnormal ADH levels can lead to euvolemic hyponatremia. This may be due to disruption of ADH by exogenous causes, such as SSRI medications, or intracranial causes, or by the syndrome of inappropriate secretion of ADH. SIADH can be associated with drugs, inflammatory conditions, or malignant disease. Without knowing the reason your patient has SIADH, it can be hard to treat, so take a careful history, examination, and investigate appropriately. If you do a fishing whole-body CT scan, you may not find anything, so focus on positive signs in the history or examination to guide you. For example, a patient with a persistent cough should have chest X-ray or CT chest, but also consider an infection screen. Check your patient's urine sodium and do a paired serum-urine osmolarity to help you determine the cause.
Pair. Noun. A set of two things used together or regarded as a unit. So paired samples equals same time. Not 3 hours apart. Simultaneous. Together. As one. Clear?
Dilute urine points you towards water intoxication or primary polydipsia. Concentrated urine would be abnormal, as the body should be trying to lose water to restore normal sodium levels. Low urine sodium would suggest that the kidneys are trying to preserve sodium and suggest fluid overload or a failure state. High urine sodium would be abnormal and probably suggests SIADH or cerebral salt wasting from neurological conditions. Management. To manage hyponatremia, find the cause and try to correct it. For hypovolemic hyponatremia, your patient will need rehydration, probably with IV fluids. However, you want to be cautious with the speed at which you correct hyponatremia, as the brain is not able to quickly adjust to changes in osmolality, and the brain cells will rapidly lose water into the extracellular fluid, leading to lysis of the cells. In particular, central pontine myelinolysis, or osmotic demyelination syndrome, can lead to irreversible damage, paralysis, dysphagia, seizures, and death. To avoid this, check your patient's serum sodium levels 2 to 3 times a day, aiming for an increase of less than 10 millimoles per litre per day. If the levels are rising more rapidly than this, assess the patient for new neurological signs, reduce the rates of IV fluid infusions, or stop them altogether and escalate early to your seniors. For euvolemic or hypervolemic hyponatremia, your patient will probably need a fluid restriction, for example 1 litre over 24 hours, to restore normal sodium levels. This may be short-term until the cause is removed, or for organ failures, this may be a long-term condition. This can be really hard for patients to tolerate as it includes all fluids: medications, IV drugs, tea, coffee, water, soup, and even liquids added to foods, such as the milk in your porridge. Patients with seizures or abnormal conscious levels, for example responsive to pain or unresponsive, that is due to hyponatremia may rapidly deteriorate. For patients presenting with these signs, you should think about putting out emergency medical calls, liaise early with your seniors, and involve critical care. They may need hypertonic saline to rapidly correct their sodium levels. To summarise, for low sodium, assess their fluid status, treat the cause, and correct sodium at less than 10 millimoles per litre per day. Don't forget to like and subscribe so you never miss a thing.